We'll just get started with the kudos and wait until 6:45 to start Dr. Henderson's talk. And so there's a long list here, and instead of reading all the details, because you all did such a great job the last few months, I will just tell you who received them and who handed out the accolades. And so Jackie Donahoe received a very nice note from the HMC night charge nurse, Malari, and nurse Dan, so thank you, Jackie. Jimmy Jew received a note from Emily von St. Andre von Arnhem, that's a mouthful, Children's Hospital provider, so thank you to Jimmy. And then Casey Peak received a nice compliment from Fiona Gallahue, who is the program director for emergency medicine. Matt Barron received two kudos, one from Nate Summers, who I think everybody knows is a physician assistant at Northwest Hospital. And then Matt received another one along with Claudia Chrisman-Scaler and Ahmad Bayomi and Daniel Hackett, who's a spine fellow at Harborview. And that was from Jenny Favinger, who's the musculoskeletal radiology fellow, whose grandmother came in with an ankle fracture to the U. Is Daniel Hackett, is he one of the shoulder fellows? Okay. I stand corrected, not a spine fellow. So thanks to you all. So this morning, can we start? We're a tiny bit early. Is that okay? Okay. Okay. This morning, it's my great pleasure to introduce a good friend of mine, Dr. Eric Henderson, who kindly agreed to come out for grand rounds today. We've been working on this for about 18 months now and solidified the details about 6 months ago. Dr. Henderson is currently an assistant professor at the Geisel School of Medicine at Dartmouth, where he's also the section leader for orthopedics at the White River Junction VA. He received his undergraduate degree in English at the University of Florida with high honors. He earned his medical degree and completed his residency both at the University of South Florida. I think you can guess he's a native Floridian. He went on to do an orthopedic oncology fellowship at Harvard and then a smaller, shorter oncology fellowship at the Rizzoli Institute in Italy, which is a very famous orthopedic oncology center. He's been at Dartmouth ever since and now is the director of research for their Department of Orthopaedics. And he's also medical director of their sarcoma service, which I know he started from scratch when he got there. He's involved in several national societies, particularly the Musculoskeletal Tumor Society. Dr. Henderson also has a VA Early Career Development Award, and those are not easy to get. And that's actually for work in total joint replacement. He is now, I think, very close to hopefully getting a K award for the work for which he's going to talk to us today. And so this is going to be a talk on direct fluorescence-guided surgery, development of methods for subsurface visualization of cancers requiring wide local excision. I don't know that much about this topic, but I know enough after speaking with Eric and Matt Thompson that this is probably applicable in a much broader way to surgery in general. And we were learning a little bit last night that this is being looked at by plastic surgeons for nerve repair, also by otolaryngologists, and I think neurosurgeons. So with that, I will introduce Kate Bellevue, who partnered with Eric in putting this talk together. One other thing I'll say, this is going to be sort of the start of our new format for grand rounds. Everybody knows we've been typically having a trio of presenters with the resident essentially doing a brief overview of the topic. And I've received quite a bit of feedback from faculty, which I in fact agreed with when I looked at it all, that we want to go back to a format where the residents are just doing a little bit more of the talk. And so from here on out, we'll be having two presenters. It will be a resident partnered with one faculty member most of the time. And instead of a brief introduction, you'll be a little bit more responsible for putting the content of the talk together. And so that'll be the new model, and we'll see how that goes over the next year. And with that, here is Kate to introduce this topic.
Thank you, Dr. Chansky. I have the honor of presenting with Dr. Henderson today, visiting us, as Dr. Chansky mentioned, from the Dartmouth School of Medicine. I will be providing an outline on fluorescence-guided surgery, and Dr. Henderson will be discussing applications of fluorescence-guided surgery and his original research in the field. Starting off with a brief introduction on sarcomas. Sarcomas are malignant tumors of the connective tissue, involving cartilage, muscle, bone, nerves, and vessels. The yearly incidence of sarcomas in the United States is on the order of about 14,000. More than 50 subtypes of sarcoma exist. They're most commonly divided into osteosarcomas and soft tissue sarcomas. They require complete removal for cure of the sarcomas. Treatment varies depending on the tissue diagnosis and the tumor characteristics. Osteosarcomas often involve treatment with neoadjuvant chemotherapy, surgical resection, and adjuvant chemotherapy. Soft tissue sarcomas often involve radiation and surgical removal. The goal of surgical resection is complete excision of the malignant tissue with negative margins. Prior to the development of limb salvage surgery, amputation was a definitive treatment for sarcomas. Limb salvage surgery aims to preserve a functioning limb without increasing the risk of further tumor recurrence. Limb salvage surgery is possible in greater than 85% of appendicular osteosarcomas. About 23% of sarcoma surgery results in positive margins. Local reoccurrence occurs in about 10% of patients treated with limb salvage surgery. Prior research has shown that there's a strong association between inadequate surgical margins and local recurrence. This highlights the need to develop new technologies to reduce the rate of positive margins in tumor surgery. Now moving on to discuss fluorescence-guided surgery, I'd like to start with a definition. Fluorescence-guided surgery involves using fluorescent imaging to identify specific structures or anatomic structures within a surgical region. These can either be tumors to highlight that the surgeon wants to resect, or blood vessels or nerves that the surgeon wants to highlight to either preserve or reconstruct. This provides the surgeon with real-time visualization of specific components within the operative field. Current applications of fluorescence-guided surgery include blood flow assessment, such as vessel patency or perfusion. This can be used in reconstructive surgery. Assessment of hepatic function, and lymphatic imaging, such as sentinel lymph node identification and mapping. Near-infrared fluorotopes are molecules that, when stimulated with specific frequencies of light, emit a frequency of light in a different frequency, such as the near-infrared range. These emit light with low tissue autofluorescence. They have low absorption but high scattering properties within the tissue in their wavelength range, which is about 650 to 900 nanometers. This results in diffuse propagation and deep tissue penetration, which then enables the localization of labeled structures despite being several centimeters deep in the tissue. The greater penetration depth is due to the reduced hemoglobin absorption in this wavelength range. Different fluorophores that are used include iodocyanide green. This is the most common fluorophore used in open surgery. It has functional groups that permit the attachment of ligands that can promote the attachment of other molecules to target specific components. Methylene blue is another fluorophore that is used. This has limited use because it has less fluorescence yield and it does not have the functional groups like ICG has. Fluorescein and 5-immunolevulinic acid are two additional fluorophores. These are not in the near infrared range. They are predominantly used in neurosurgery. They emit fluorescence in the visible light range, which can result in high background autofluorescence, in contrast to those in the near infrared range. The visible fluorescent emissions from these fluorophores are on the order of 10 to the 5 times less energetic, and they lack tissue penetrance. Fluorescein penetrates brain tumors via the defective blood-brain barrier. 5-ALA is a prodrug that results in the increased synthesis and accumulation of fluorescent porphyrins. ICG is able to penetrate tissue because it's hydrophobic and binds to the proteins in plasma. This confines it to the intervascular space. ICG can then extravasate into tumors due to enhanced permeability and retention. This is due to the increased vascular permeability and decreased lymphatic drainage in tumors. Additional research in the field is commonly focused on different approaches with ICG, as well as the development of targeted molecular contrast agents for specific features of tissue. This picture highlights a peripheral nerve cell that is highlighted with autofluorescence in the surgical field. Targeted molecular agents involve conjugating near-infrared fluorophores with cancer-targeting agents. These can be tracers that detect vascular, structural, metabolic, immunologic, or genetic components. Current research is looking at monoclonal antibodies that are directed against cancer-specific proteins, as well as ligands for specific tumor receptors. In practice, most surgeons predominantly rely on visual and tactile cues, along with preoperative imaging to guide tissue resection. Surgical oncology can greatly benefit from fluorescent imaging technology and targeted molecular surgical guidance to direct the removal of tumors. Neurosurgery has been effective in applying fluorescence-guided surgery in the resection of brain tumors. This study is out of Germany, and it used 5-ALA to target and aid in the resection of malignant gliomas. This is a phase 3 randomized control trial. 322 patients were randomized either into a conventional microsurgery group with standard OR white lights versus a group that was randomized to 5-ALA fluorescence-guided surgery resection. The patients in the 5-ALA group ingested a solution of 5-ALA 3 hours prior to surgery. Their surgeries were done under a microscope with fluorescent light, in contrast to the patients randomized to the standard group. They did not ingest the ALA solution, and surgery was done under standard conventional OR lights. The results of this study reveal that complete tumor resection occurred in 65% of the patients who underwent fluorescent-guided surgery, and only 36% in the patients under the standard conventional white light. They found that the 5-ALA treatment group had a higher rate of 6-month progression-free time. Overall survival did not differ between the two groups, but this study was not powered to detect long-term differences in overall survival. And overall, there was no difference in frequency of adverse complications. While there have been successes and research in other fields of medicine with fluorescence-guided surgery, there's limited published data within the field of orthopedics. Therefore, we are excited to hear about the research of Dr. Henderson and his applications within orthopedics. With that, I would like to introduce Dr. Henderson to speak.
Kate, if you could come to help me with every talk I ever give, because that was great. That would be phenomenal. So thank you very much for having me. It's truly an honor to be here. And it's an honor to be invited by Dr. Chansky. I've really enjoyed meeting him and knowing him over the past 3 years. And I will say that this is the first time I've actually presented this information as a whole. And so the first time I do anything, it tends to not go as well as it should. And so if anything's not clear, please raise your hand or let me know afterwards how I can start clarifying things, because I realize that's going to be part of the process. So the research I'm going to talk about today is kind of in a nascent phase. We are trying to take fluorescence-guided surgery into a new realm. By using it more indirectly and seeing things before they see us. In terms of disclosures, so we have a couple pilot grants from local foundations, Norris Cotton and the Hitchcock Foundation. We have an OREF grant. I have my VA CDA, and then we recently, just in the past 2 weeks, found out I got my first NIH grant, so I was very excited about that. There's really no industry support, though. I received nothing personally. But Dartmouth does own partial rights to ABY 029, which I'll be talking about today. So essentially, we're going to go over the case for improved surgical guidance, which Kate's already laid out very well, so I can skip over a lot of those slides. Talk about a brief history of fluorescence in medicine, again, which Kate has touched on most of that, so we can skip over a lot of that. And then we'll start talking about sarcoma as a model disease for this new method of trying to see tumors more indirectly. Then I'll basically go through the work that we've done so far and then talk about next steps. So the case for improved guidance in surgery. I think that all of us as surgeons want to provide the best care that we can, and we want the operating room to be a safe place, and we want to provide the best surgery, which really, in my mind, means being accurate, being precise, having your results be reproducible, and doing things more quickly, getting patients out of the OR faster. So when I talk to my residents about effective surgery versus safe surgery, in my mind, effective surgery, I think of the Navy SEALs. You've got a mission, you want to get in there, you want to do it quickly, you want to do it well, and then you want to get out. One of the hand surgeons I trained with used to say, your first goal in the OR is to get the hell out, but get the mission done in the meantime. On the other hand, for safe surgery, you want to tread lightly. I think of a walk in the woods. Bill Bryson actually used to live right down the street from where I live. And you want to stay on the path, you want to respect the wildlife, don't litter, and be kind to the environment. So kind of combine those two. So our anatomical knowledge is really the foundation for being effective and safe in the operating room. And there's danger everywhere, right? Especially if you operate in the pelvis or if you operate in the spine. There's bad things out there. And as my colleague, Dr. Coe at Dartmouth likes to say, that danger takes no holidays. So the tools that we have right now, and Kate touched on a few of these, is we have our knowledge of anatomy. We have our imaging, we have our visual and tactile cues, and then we have adjuvants like the Doppler and the nerve stimulator to add to our ability to understand the anatomy in surgery. In these days, everyone is a special snowflake, right? And from an anatomical standpoint, that's usually not true, but there are cases where that is true. So in the case of trauma, anatomic anomalies, tumors, prior surgery, and radiation, and tumors and radiation apply to me quite often, you have situations where the anatomy is abnormal, or in the case of radiation, the anatomy looks different. With a radiated leg, a tendon may look like a nerve, may look like a vessel, and so it's hard to discriminate what things are. This is a recent case right here, and basically all the important structures after radiation look the same. And with the changes in tissue, an artery no longer feels like an artery, and so things become a little bit more confusing. Now, CT-guided navigation has been a great adjuvant for a lot of orthopedic surgeons. The problem is that it's only effective with inelastic tissues, right? And even with inelastic tissues, position and registration of your points is a very important part of it and can lead to inaccuracy. So the issue with elasticity is if you make an incision in a elastic tissue, suddenly everything changes. Even though if you knew where the tumor was exactly before that, you make an incision and things start to change. So the problem with CT navigation is that elastic tissue changes orientation as you intervene in it. And so the goal, in my mind, is to create something which is real-time, provides direct visualization through the tissues so that you can see things and see as they change position through the course of the surgery. So a brief history of fluorescence in medicine. Fluorescence was first described in the 1500s, and there is a tree, the Nara tree, which its sap produces a fluorophore called mataline, and it fluoresces in the white light spectrum, and was described back then. So more recently, these four gentlemen described fluorescent emissions from calcium chloride, from chlorophyll, and quinine, and then Stokes actually described the term fluorescence to indicate the change in wavelength from one light emission coming into an object and then changing, coming back as another one. And this led to the term called the Stokes shift, which is the difference in frequency between the two. So what's actually happening with fluorescence? Well, so there's some form of excitation energy coming into the system, usually in the form of a photon, which excites one of the peripheral electrons, and then it goes up from its ground state, and as it relaxes back to its ground state, it emits another photon. And it is it's never higher energy than the original one. That would violate the laws of physics. So it's usually either equal to or lower, and usually lower to, because usually some energy is lost in heat or some other dissipation means. So why is this useful? Well, so each fluorophore has a characteristic excitation energy and a characteristic emission energy. And so if you can label each tissue type with a different fluorophore, then you can presumably know what you're looking at through fluorescence identification, and essentially, create kind of an operate by number situation. And here you see a whole bunch of different fluorophores, and you can see immediately why fluorescein was so attractive as a early fluorophore, because if you scale down, actually it's right here, number 17. So it's right in the green, so it's very visible, and also the brightness is extremely high, by orders of magnitude more than most of the other fluorophores. So in terms of fluorescence in medicine, fluorescence was first described for identification of retinal injury in 1926. Fluorescein was first used for glioma surgery in 1948. ICG for retinal, and then fluorescein for gliomas. But this study, or the approval of 5-ALA in 1999 touched off what's going on today, which is kind of the fluorescence-guided surgery revolution, because 5-ALA is a precursor, as Kate pointed out, to protoporphyrin 9, which is a fluorophore. And so glioma tumors readily convert 5-ALA into protoporphyrin 9. And so Stummer published the first paper in 2006 showing this huge increase in disease-free survival. And so that got a lot of attention. So and Kate touched on this, so fluorophore types. So again, as Kate said, we have vascular perfusion probes. We have metabolic probes, which like 5-ALA, where you have a precursor, a substrate. The cathepsin probes that are being used at Duke right now, LUM-015 would qualify as this. And then we have molecular targeted probes, such as the BLZ-100, which was developed here, which I'll touch on. So again, so fluorescein and ICG are the two kind of grandparents of fluorescence-guided surgery, if you will. Here you see their excitation and emission profiles, and you can see they're quite different. And again, as Kate touched on, so fluorescein is readily visible in the green region of the white light spectrum, visible light spectrum, and ICG is in the near infrared. And then so 5-ALA, again, initially approved in 1999, not for fluorescence-guided surgery, but actually for PDT, so photodynamic therapy, with actinic keratosis, and then enterprising neurosurgeons realized, well, 5-ALA is a precursor to protoporphyrin IX, so we can use it off-label for gliomas, and so they did and showed really good results. So here you see the excitation and emission bands for protoporphyrin IX. So here, BLZ-100, which was developed here in Seattle, this is a targeted probe which targets annexin, which is a multi-use protein within the cell, which is, it can be used for motility, for cell structure, but targeting that, it's a very important component to gliomas, and this was the first to phase 1 trial, and actually on clinicaltrials.gov, there are 5 trials listed for BLZ-100 right now, 3 of which are active. So, limitations of the current technology, though. So the current technology all relies on the surgeon seeing the tumor, seeing it actually physically. And so this works fine for, and has worked very well for urologic cancers, for brain tumors, for ENT, where you're doing a surface dissection and you're not trying to do a wide local excision. But in the sarcoma world, as Kate pointed out, you don't want to see the tumor. You want to go around it, and in this case, you want to have a nice cuff of muscle around it so that you know that you got it all. And so that technology has not been developed. Now, the folks at Duke have published some really nice work on using a near-infrared camera that they have used. So they've been labeling sarcomas with this LUM-015, and then they've shown an improvement in so the recurrence-free survival going from positive margins and then addressing positive margins with their camera and re-resecting tumor, and they've improved results to a dramatic fashion. So, and this is great, but wouldn't it be better to try and just avoid negative margins altogether? And so that's kind of the challenge that I've been working on with the POG and the SAMCO labs. So trying to see the tumor, through subsurface fluorescence. And again, Kate did a great job of this, so I'll just gloss over this. But what is a sarcoma? So when this happens, around day 15, the tissues start to layer out into the germ layers. The mesoderm forms the muscle, PNS, cartilage, and bone. And then if this goes bad, and bad meaning uncontrolled cell division and metastatic potential, you end up with a sarcoma. So in sarcomas, our generally treatment involves a negative margin surgery, so a wide local excision, previously a radical resection, and as Kate pointed out, the positive margin rate in the largest series by Pisters, which was published again 20 years ago, but it really hasn't changed all that much. I think that 22% is a little on the high side, but still positive margins are a problem. So what do we want? What we really want is to be able to see the tumor, see the critical structures, and then see our way around the tumor, knowing ideally what our margin thickness is without actually ever seeing the tumor. Now, so this is a case that I presented, and this actually kind of kicked off this because Dr. Mirza, my former chair who hired me, he asked me to come present at his research meeting one month, and it's the last thing you want to do. You're tired, you've got all this stuff to do, and but I basically went in there and just presented a case that I thought was the future of sarcoma surgery, because sarcoma surgery really hasn't changed that much over time. And so I basically said that we have the technology to label bone, and wouldn't it be great if we had a myogen targeting fluorophore, and we could identify the muscle. We could target maybe a dipsin with a monoclonal antibody and another fluorophore. And then the vessels we can target pretty easily with a contrast agent. Nerve, there's actually a new fluorophore out there, oxazine 4, which targets nerve very specifically. And then if we had this is a one with leiomyosarcoma, if we had a smooth muscle actin targeting monoclonal antibody, wouldn't it be great if we could target the tumor with that? And I basically said I think this would be the future of sarcoma surgery. And a gentleman in the audience, Brian Pogue, who is a multi-million-dollar NIH-funded researcher in optics and medicine, at the end just turned around and said, I know how to do this, and we can do it together. And so we've been working together for the last 3 years. So in terms of how to get there, though, the questions you've got to answer is, so let's say that this is a crude model of a tumor. So does the fluorophore bind the tumor? And then if it does, you've got tissue around it. So can you see the fluorophore through the surrounding tissue? And then maybe you can, but does the fluorophore bind to the surrounding tissue? And if so, how readily? And can you actually see the tumor through the surrounding tissue? So I created this checklist, which has been increasing in length. If this is our goal over here, how do we get there? And so we need to have a fluorophore that binds sarcomas. We need to have, ideally, an ex vivo surgical model, so we're not, killing hundreds of innocent rodents, and then an in vivo surgical model. We need to know what tissue penetration is. We need to know what tumor fluorophore uptake, the uptake in the background, drug biokinetics, how do the surgical imagers work, and the dissection accuracy. So this really gets into the meat of the work that we've done, and so we'll just go over it as an aggregate. So in terms of a sarcoma binding fluorophore, there's been work done to show that small molecule binding fluorophores work better, especially labeling the periphery of tumors, which is what I want. The central part of the tumor isn't as important because you're going to lose all that signal. So small molecule binding fluorophores work better than full antibody fluorophores. And so Dartmouth, in collaboration with these groups here, has developed this ABY029, which is an affibody. And so what is an affibody? Well, it's just a small fragment of an antibody, and it's just the binding region, essentially. And so in this case, it's a 56 peptide protein. So, and it binds EGFR, and it's linked to IR-800. So is that going to work for sarcomas? Well, about 60% of soft tissue sarcomas are EGFR positive, so it probably would work pretty well. So this has been what we've been pursuing. Now, does it bind the sarcomas that are EGFR positive? Well, this is coming from our SW982 is a synovial sarcoma model, and it actually, ABY binds quite well. You can see over here. And then in terms of its discrimination between the synovial sarcoma and normal tissues, these are rodent tissues, you actually get excellent discrimination between the two. And I've actually got more objective information than just visual for later on in the talk. So yes, I think that hopefully we do have a sarcoma binding fluorophore. Now, in terms of the performance of the various imagers that are out there, so one of Dr. Pogue's postdocs, Alicia, did this really nice study where she looked at all these features of the various imagers out there. And normally this slide would never actually be visible, but with this excellent auditorium you have, you should watch football in here. You can actually see this. So the winner was the Perkinelmer Solaris, which not surprisingly is the most expensive one. But this is the one that we went with, and they actually gave us a discount, so we have this in the lab now. So we also wanted a reliable ex vivo surgical model, so again, that we're not killing hundreds of rats. And the factors that went into developing this and the motivation for it, again, animal kindness. We also want something which is very reliable and reproducible. And one of the problems with a rodent model is that the rodents really don't have much in the way of subcutaneous tissues. They don't have the subcutaneous fat depths that humans do, especially Americans. And so having the ability to simulate thicker connective tissue was good. And also the cost. I mean, even though rodents are small, they're expensive. You have to keep them alive. Whereas phantoms, you can develop on a PRN basis. So in terms of creating a successful tissue simulating phantom, recreating absorption and scatter of photons within the phantom that replicate human tissue is the most important aspect. And you need to be able to include fluorophores and inclusions into the matrix. You want them to be time stable so they can be made and used the next day, used a couple days later, and plus you don't want them to be too expensive or too hard to make. So again, the major components: a matrix agent, a scatter agent, an absorption agent, and there's some nice work done by Dr. Pogue to look at the various components. And so intralipid, which is basically emulsified fat, has been proven to be an excellent scatter agent. In terms of absorption agents, whole blood is excellent, so usually bovine blood. And then fluorophores can be incorporated. And so what we did is we created these wells of fluorophores, and we basically did different combinations of intralipid and blood until we essentially found mixtures that successfully replicated human fat and human muscle. And this is how we developed. So these are our recipes, as you will, for the phantoms. And we have used these to good effect. And so this is the finished product. And so essentially what you have is this opaque cylinder that you really cannot see through. And then for a lot of the work that we've done, we'll go over the results in a second, the lab assistants will make these up, and they will hide within these somewhere an inclusion, which is the tumor, so to speak. And then it's up to me with various background concentrations and various concentrations within the inclusion, to try and go after it and dissect it out, with a wide local excision, essentially. So next, we need to know, how much tissue can we see through? Can this actually work? Because if not, if we can't see through depths that are useful for sarcoma surgery, then there's really no use in going forward. So 2 centimeters was kind of our goal. And so we developed this phantom model here, where we basically had a base, and then we had this inclusion that had ABY029 in it, and then we would put these wedges on top of it and tilt it, and then see how far into the wedge can we see. And we did 2 scanners, the Lycor Odyssey and the Lycor Pearl. You can see the recipes here, and we use an 8 millimeter inclusion for this. And so what you can see here, this is the most important, but the PhDs I work with swear that you need to see the rest of this, which is a little bit more confusing. But here you can see that as you go further down, you obviously lose signal. But if you zoom into the tail end of that, you can see that you can still get fairly predictable decreases in signal up to 30 or 35 millimeters. So that's pretty good. My goal was to see through 20 millimeters, and this is what you see with the machine. So we also looked at other concentrations more indicative of muscle. That was more indicative of fat. And again, you can see that with higher densities, it's a little bit more unpredictable there at the end, but you can still see through a fair amount of tissue. And these are some different variations of the intralipid and blood. Again here, but really this is kind of the take-home slide, and you can see that with these different concentrations, you can generally see up to about 30 millimeters in depth. So 3 centimeters, which was what we wanted to see. We also did this on the Odyssey, that was on the Pearl, and we basically came up with the same numbers, or similar numbers. The Odyssey was a little bit less accurate, a little bit less sensitive. So then, that was just with we held the inclusion size constant there. So what if we vary the inclusion size and the concentration within the inclusion? So here you've got these hot dog looking things, and we basically, various size hot dogs, and we essentially varied those sizes and then repeated the same study. Again, we have the recipe, and this is what we saw. So you can see that as the inclusion size goes up, you can see higher signal, but the amount of tissue you can see through didn't vary too much. Obviously, a bigger inclusion got you better signal and better discrimination, but you could still see fairly well, especially up to about 2 centimeters with muscle. And with fat, you can see a little bit further, maybe 2.5 centimeters. And however, we introduced background contrast, so we put fluorophore into the background at a 3-to-1 ratio compared to the inclusion, and you can see that with muscle, with 3-to-1 background, that the results are pretty mixed, and so this may not work well for that. But in fat, you still had excellent results, even with 3-to-1 in the background. So here we did the same thing. This is with the Odyssey. The results are fairly similar. So 3-to-1 contrast, the take-home is 3-to-1 in contrast in muscle, may not work with current technology. So we also looked at the effect of the inclusion fluorophore concentration on the actual concentration of the inclusion. And here you can see the results are a little bit more rough, but as predicted, as the concentration goes up, the signal intensity in general goes up, but not quite as linearly stacked as we would like. Now we're trying to get more into the actual, where the rubber meets the road part of this. And so can we actually dissect, with what we know now, can we actually dissect out a phantom, an inclusion from a phantom with negative margins using, in flight terms, what I would call instruments alone or instruments only navigation. And so essentially we were creating phantoms. I will admit this was photoshopped. We couldn't really recreate a nice picture of what you actually see, but what you actually see with the Solaris turned on, if you have zero background, is you essentially see the tumor inclusion highlighted in this manner. And so I would basically begin serially sectioning these. And then this is not Photoshop, this is actually what you see. So you can see that once you finish, you've got this, you can see the inclusion within the tumor, but you can never see this with white light because the phantom matrix, again, is opaque. So this is really the goal. So we're accomplishing what we want to do, but we're not doing it in animals yet. And so we would measure the margins, essentially, of the tumor, and then plotted them out and found that really the margin distance, which is on the x-axis here, really plotted out nicely compared to the concentrations that we saw in the signal. And again, we would expect the higher concentration inclusions to have higher signal. And so this all plotted out in a very appropriate and predictable manner. And here you can see what the various inclusions looked like at various concentrations. And it appeared that these concentrations would all work pretty well, especially with no background contrast. We did find, though, we did make up some 4,000 nanogram per milliliter phantoms or inclusions, and there appeared to be a ceiling effect. And so at some point in time, the fluorescence becomes saturated, and so higher concentrations really don't have an effect. So the conclusions from this is that, basically the take-home message is that it looks like this method would be feasible, under the right circumstances. So low background, high concentration in the tumor, and therefore we need to do more work to continue to develop this and actually do it in animals. In terms of the ABY 029, so if we're going to use this in people, we need to understand when is the optimal time for dosing. And so here we took these 5 EGFR positive tumor lines, and then we injected ABY 029 into mice, and then mice were sacrificed at various time frames after administration to see what the concentrations were. So in the EGFR positive Ewing sarcoma model, you can see the time frames here, and so appeared to peak around 6 hours. For the synovial sarcoma, peaked a little bit earlier. For epithelial, it peaked more. Actually, it never really peaked, so we don't even know where it would peak. And for leiomyosarcoma, you see the results here, and then for fibrosarcoma. And then when you see, when all the cell lines were combined into best fit lines, or all the mice were combined, you can see here that, the take-home message here is probably that dosing in the 4 to 8 hour range before tumor dissection is probably ideal. And so this is what we're going with the phase 0 trial that we're starting now, the first in human study of ABY. I mentioned earlier about, what are the background tumor effects? What, if the background takes up the fluorophore, how is that going to affect our outcomes? And so here you can see these are actually tumors being dissected in vivo from rodents. So this is at 1 hour. And again, based on the results we just looked at 1 hour, we wouldn't expect to see much in the way of fluorescence, and that's actually what we see. But here at 8 hours, you can see that the fluorescence is much greater. And so then the tumors were removed, and you can see there's a huge difference in terms of the fluorophore, or the fluorescence that you see when the tumor is sectioned and scanned. And compared to the normal tissues, you see pretty excellent discrimination. And nicely, you saw in the curves that in the normal tissues, the ABY concentration actually decreases in the 4 to 8 hour window, wherein with the tumor, it continues to increase. And so that's really what we wanted to see. And so in terms of what you're seeing here is here, this is a control. So this is just IR 700, which was injected intravascularly. And then here you see ABY, which was injected as well. And this is all normalized to muscle. So muscle has been normalized to 1. And you can see the contrast ratios here of the various tumors compared to fascia, nerve, muscle, and fat. And so, for fascia, nerve, muscle, and fat, you get a pretty nice, and probably on average of 3, 4 to 1 ratio. And versus fat, it's a little bit lower. So that, that may be a problem. But in general, we get a pretty nice ratio of signal from the tumor to the surrounding connective tissues. So in terms of A, though, now, so those ratios sound nice, between 3 and 4 to 1, but really, is that good enough? And so that's what we looked at next. And basically, again, same ingredients. And what we did was the lab did dissections where they did very precise removals of matrix around the tumor inclusions, and then basically developed a model saying that at this depth you can expect this fluorescence, at this depth you can expect this fluorescence. And then they had me dissect various inclusions out from tumors at different backgrounds. And you can see here that, so here's the, here are the results. And number one, there were no positive margins, so that was great. Even with 2 to 1 inclusion to matrix ratio, we still never had a positive margin, which was great news. And kind of predictably, though, you can see a wider spread, larger standard deviation in the margin thicknesses for 2 to 1 ratio compared to infinite ratio, so no background, 10 to 1 and 5 to 1. But still, even up to 2 to 1 appears to be a ratio that's good enough to enable you to do negative margin surgery, at least under more ideal circumstances with a phantom. So the results from the last study, combined with this, are encouraging still that that our uptake seen in tissues right now may be good enough. So even a 2 to 1 background ratio appears to be sufficient for a wide local excision. And then so a final test of surgical accuracy. So armed with that information and then other information that we had from just doing multiple dissections, basically what we did last week, I was on vacation last week, but I came in on Thursday to do this because we really wanted to have this data for this presentation. What we did was they told me essentially, all right, I knew what the inclusion size was, but I was presented with numerous phantoms, and then was told to dissect down to either a 2 by, or because it's a 2 by 2 by 2 inclusion, either dissect down to a 4 by 4 by 4 specimen or dissect down to this signal, this fluorescent signal intensity. And so we did that, and the result is that, again, we never had positive margins. And the predicted intensity was generally lower than what the actual was. And so our modeling isn't quite right yet. There's some nuances that we have to figure out. But the nice thing is that even with the various contrast ratios, we could still obtain negative margins when performing these procedures essentially by instruments alone. So, because again, I'm doing this with no idea where the tumor is, where no surgeon's really going to wander blindly into a surgery, not having looked at the MRI, not having looked at any type of imaging. And so with instruments alone, we seem to be able to have pretty good results. But fluorescence values right now are not sufficient, because if I had kept going, or if I'd gone just to the predicted, probably would have either had too much or too little margin left. So, and that's pretty much the end of the results of the talk. I do want to emphasize, though, that the technology's not there right now, and there's plenty of instances in the news where instrument alone navigation has failed. I don't want to pick on that one person, but conclusions from the talk. So ABY appears to be a good sarcoma marker. We have not really, it's obviously going to be more applicable to EGFR sarcomas, which appears to be over half of them. But for the EGFR negative sarcomas, we're going to have to find something else. 2 to 3 centimeters of subsurface visualization appears to be feasible. And the fluorescence signal does seem to vary in a predictable manner with tumor size, with fluorophore uptake, and then the tumor to background binding ratios do appear to be adequate for this indirect subsurface fluorescence, and especially when the injection to surgery time is greater than 4 hours, when you've allowed the soft tissues to clear ABY and the tumor continues to bind it. So next steps, I saw a new patient. We just received approval to start our phase 0 enrollment, and the first patient I've seen since then has agreed that she would sign up, so she's going through radiation right now. And we're also going to, speaking of radiation, we're going to have to determine what are the effects of treatment, aka radiation and chemotherapy, on fluorophore uptake. We're going to have to look at the effectiveness of maybe we can enhance the tumor discrimination by using a perfusion probe and a targeted probe, because perfusion probes do work pretty well for tumors, because tumors tend to be highly vascular. And then, we need, at some point, we're going to have to really develop a model for margin estimation based on this, because that's really the whole goal. And then, what Dr. Chansky alluded to is that I really think that in the future, this is going to have more broad use. There's going to be the ability to, you're going to try and identify normal tissues as well, not just the tumor, and be able to discriminate those. And in effect, we're one of Dr. Pogue's graduates, who's an assistant professor in Oregon. She's Dr. Gibbs. She is working on a fluorophore that she has pioneered that really binds nerve very, very well. And so this may have implications for trauma surgery, for making decisions as to amputation versus limb salvage. When you're doing a washout and potential amputation for a 3C tibia. At 2 a.m. And then, I'll just leave you with, we talked about this last night at dinner. I firmly believe that, if assembly line robots can build a complete vehicle in 17 hours, combined with the computing power that we have these days, I think that having robots in the OR, and doing a femoral nail, and I think that in 50 or 100 years from now, I think a femoral nail if we even do femoral nails at that point, could be a 2 to 4 minute surgery. And I really think that is going to be the future. So I'd like to just recognize all my collaborators. This work mainly comes out of Dr. Pogue's lab. He's really a giant in this field. And, but you can see everyone else who's participated too. And thank you very much.
We have time for questions.
That was awesome.
Oh.
And it's inspiring to see you kind of methodically going through these steps. When we're resecting tumors, a lot of times there's extrapolating from what they've done in the pediatric neurosurgery realm with the tumor paint and scorpion venom. They don't have 2 centimeters of margin in the brain, and what they're saying is, I can't give anything up.
Right.
How close can I get?
Mm-hmm.
And when we're dissecting, so thinking about you're near the physis or you're right against a structure and you're not sure, you'd like to be able to do a limb salvage, but you're worried that your margin's going to be really close. Are you looking at all at a way to see not how far away you predictably can get, but how close you can get and still have a negative margin?
Yeah, we haven't done any of that work right now. So Brigman and Ewart at Duke are more in that vein. And actually, they published a paper, I think it was early last year, where they've actually developed a very kind of space age tool where they've got a laser targeting device essentially that sees the residual cancer cells marked with the LUM015 and actually ablates them in real time with a laser. And so I think that dissecting tumors, number one, I think that in 50 to 100 years, I think that most cancers won't, or probably all cancers won't require surgery anymore. I think that we'll have target agents for everything, and that people like me would be out of a job, which would be great. Then I can go be an arthroplasty surgeon and make a better living. I really, I think until then, I think that doing wide local excisions is actually kind of a crude method of doing surgery, because you're taking out normal tissues. And I think the gold standard for cancer surgery, until that day of targeted agents, I think the gold standard for cancer surgery is to just take out the tumor and take out nothing else. And so I really think that would be the future, and I think that is achievable. I'm not sure which will win out first, that versus targeted agents for all cancers.
Anybody else?
Kind of off the topic a little bit, but since we have residents and stuff here, I was going to ask you kind of how you made this happen, because this is a lot of basic science stuff where you spent time, a lot of your own time, probably in the lab working directly with PhDs and researchers who have different schedules from surgeons and things. So what was kind of your roadmap? I know we talked about it a little bit last night, but perhaps for our resident training audience.
It was really a happy accident, which I think most of the good things that have happened in my life have been like that. I mean, when I was in residency, I happened to be at Moffitt Cancer Center with Doug Lutzen and ended up publishing a lot on outcomes from endoprosthesis for patients receiving endoprostheses for limb salvage. And then I got up to Dartmouth, and we had no sarcoma program, we had no database, we had nothing. And I'm sitting there going, well, I'm supposed to be academically productive, and what am I going to do up here? Because I've got no patient volume, and so I built a practice, and slowly. And I was talking to Matt about this last night, that he's coming in here and we've got the exact opposite problems. He's going to be hit with a flood of cases potentially, and so I just tried to talk to everyone I could, and I ended up meeting Dr. Pogue, who again, just kind of heard my ideas and said, I can do that. And Dartmouth just built a research building connected to the hospital, which is for the Dartmouth Institute and for Thayer engineers. And it's been, for me, it's been a godsend, because, I can just walk upstairs and be in the lab, and you know, I can troubleshoot ideas with people in real time. And so I would just say if you go into academics and you're at a place where you don't have a body of research to immediately draw from, you know, just go and meet as many people as you can, be as friendly as you can, you know, and talk to people, because ideas never work in a vacuum.
So thank you, that was, I agree, that was a fantastic talk, and you've taken it from basic science to something that's actually relevant to your surgical practice. Yeah, I'm really impressed with it. And I would say you had on several slides, no financial disclosures, and I hope that this becomes something that's broadly used, and you can financially capitalize on it, and I'm sure you'll put that money to great use. And by the way, I was also looking at my resume. Time flies. We actually met just before I turned 50, and I am much closer to 60 now, sadly enough. So this is a tie and an honorarium. Eric very kindly asked that we donate his honorarium, so we are going to give it back into his research program. I'm sure that will fund a few minutes of the work you're doing. And this is a plaque, and thank you again for traveling out here.
Oh, well, thank you very much.